So my name is Evelien Gevers. I'm a pediatric endocrinologist. I work at Barts Health in East London in the UK, and the university there is Queen Mary University of London. So Prader-Willi syndrome is a rare disease, 1 in 15 to 20,000 children affected. It's a genetic condition where there's an abnormality of chromosome 15 Q11 to Q13, and that is either because you're missing the part of the paternal gene, or you have two copies of chromosome 15 from your mother, maternal uniparental disomy, or you have an abnormality in what we call the imprinting center. And the condition is severe. It leads to neonatal hypotonia, so being very floppy, which then can lead to breathing difficulties and feeding difficulties, and at later age leads to reduced calorie requirements because the muscle tone is very low, muscle mass is very low, and then later on increased interest in food and hyperphagia, so always hunger, and reduced satiety when people eat, in combination with a learning disability and also behavioral abnormalities that over age can become more and more severe. There also is a very frequent problem is also skin picking, where patients pick anything on the skin that isn't completely smooth. That can lead to bleeding, infections, etc. So it's slightly different to other rare diseases, where indeed there often is a very long diagnostic journey. We hope with Prader-Willi syndrome that because of the neonatal hypotonia and the severe floppiness, that it's picked up in the first few weeks of life really. And that does happen for many patients. What we don't know is how many patients are actually not picked up in those initial few weeks. And that is what we did a little bit more research in. Initially, just by guiding the family what Prader-Willi syndrome is, explaining to them that initially the babies will have feeding difficulties, often need a tube through their nose for feeding, but that over time they will require fewer calories and then become very hungry. So if you prepare parents for that journey, they're more able to adapt, so that's really important. And then the only other medication that we have is growth hormone. Growth hormone helps to reduce fat mass, but also increase muscle mass. And it's been shown that if you start growth hormone treatment before the age of 1, that you have better outcomes compared to after the age of 1. And we really are trying to start growth hormone treatment well within that time period, if possible before 6 months of life and even earlier. So that's why that early diagnosis is important. And further management of the condition indeed is to support the families and the patients, see them frequently, have dietary advice, very individualized, ensure that people understand that they have a reduced calorie requirement, but also that they're always hungry, and that therefore you need to really keep them away from food or keep food away from them, and that they often like to have quite a routine when they know exactly when they're going to be eating next, and know what they're allowed to eat. We work together with the Prader-Willi Syndrome Association in the UK and also with our genetic laboratory to find more out about the age of diagnosis. So when we looked at the patients that are registered with the Prader-Willi Syndrome Association, they noticed that in the last few years there were more patients that they felt were diagnosed late. So when we looked at that in more detail and looked at when patients were registered with the association and when their reported age of diagnosis was, and we look back until the 1960s, then initially, as expected, we found quite a few patients that were diagnosed above the age of 1, and then in the early 2000s that number reduced every year to then reduce to about 7 patients in the 5 years 2015 to 2020. But then after 2020 there were 13 patients, even in the last 2 years. So it seems that maybe there is delay in diagnosis that is quite recent. Maybe COVID is involved and the patients were recognized later at that stage. So when we looked at the 13 patients that were registered with the association in the last 3 years, really, about half of those were diagnosed below the age of 5. But above the age of 1, and the other ones were diagnosed at 11, 14 and above 20 years of age. So that was clearly concerning. So then we did an audit in our genetic laboratory in London that covers an area of about 10 million people. So it isn't the whole of the UK, it's about 20% of the UK. And they found that in 3 years, so we looked at 2019 to 2022, and they had 59 requests for Prader-Willi syndrome testing, and they found that 10 of those requests actually were incorrect requests, so the wrong test was requested, because for Prader-Willi syndrome it's a very specific test that you want to have, called a methylation test. And the test that was requested in 10 of those patients was incorrect, a marker array that doesn't necessarily pick up all the genetic causes for Prader-Willi syndrome. But out of those 59 patients, they found that 28 patients were positive for Prader-Willi syndrome, so that's a yield of 47%. And most of those tests were requested by neonatologists indeed. And when patients were referred below the age of 1 month, then they were most likely picked up with Prader-Willi syndrome, and that had a yield of about 90% if they were referred for testing below 1 month. But then there were also a bunch of patients that were referred after the age of 1 and even after the age of 18. So there were 4 patients that were referred after the age of 18. Yeah, about 7 or 8 patients between the age of 1 month and 5 years. And when we looked at those in more detail, the patients that were above 18 years of age, it's difficult to know whether that was confirmation of clinical diagnosis or maybe a repeat genetic test, because patients were transitioned to adult care, and unfortunately we don't have the exact information of those patients, because that's just, we can't get back to the hospital that the patients came from. So we are not 100% sure. I think the most concerning patients are those that were referred for testing between 1 month and 5 years of age. So 2 of those patients were clearly missed. 1 patient was eventually referred at 8 weeks, which is still relatively young, but already presented at birth with feeding problems, was seen at day 5 with feeding difficulties in A&E, came back later on with a viral infection, was then admitted at 8 weeks of age because of breath holding spells, problems with breathing, which is very likely related to Prader-Willi syndrome. The child was noted to have dysmorphic features, and then eventually a genetic test was requested, which actually wasn't a specific test for Prader-Willi syndrome. So that was clearly a patient that could have been referred at day 5 of life, if not earlier, but was only referred at 8 weeks, and was picked up despite the wrong test having been requested. That child came from a general hospital, so we also think that maybe if we do a bigger audit and we look at where patients are referred from, it may be that they come from specific hospitals with fewer exposure to Prader-Willi syndrome and less experience. Then the second patient was a patient that actually was referred at 5 days of age, but somehow there was no genetic result, and then was re-referred again at about 6 weeks of age. So again, missed, but possibly for different reasons. And then there was a child at the age of 5 years and a child at the age of 7 years that both had a very clear history of neonatal hypotonia and floppiness and the clear symptoms of Prader-Willi syndrome, but despite that were not referred early at birth. So they also were really misdiagnoses. So those are the patients that I worry about the most, probably even more than the patients at this stage, more than the patients that were above 18, because I don't have enough information to know whether they were really missed patients or whether they were diagnosed clinically or diagnosed already with a genetic test and repeat genetics. And so what we now hope to do in the future is to roll out an audit over the whole of the UK to get more information about other areas, whether there is a regional difference, because still the numbers that we found from the Prader-Willi Syndrome Association are actually higher and at older age in childhood compared to what we found in the audit. So in the Prader-Willi Association they had about 5 patients in the last 4 years that were diagnosed at the age of 3, 4 and 5. And so if you think about when those children were born, so in 2020, 21, 22, that clearly is a time that we should be able to diagnose patients very early after birth. So therefore we want to look in the whole of the UK how the pickup is in different areas of the UK. Guidelines that were written in 2008 said that most patients were now diagnosed in the first few months or year of life. The newest review says that most patients should be diagnosed in the first few weeks of life. There isn't any clear guidance that says you really should aim to have a diagnosis before 1 month. I think that's what we should work towards, that there should be a guideline where we say we aim to have a diagnosis before probably 2 months. 1 month is really difficult because there are also turnover, you also deal with turnover in the genetic lab. So 1 month I think is ideal, but very difficult. But we should really aim to have the majority of patients diagnosed before 2 months of age. I think it would also be really interesting to see how age at diagnosis differs in the different countries, and also in the different countries where there are regional differences, and if there are countries that perform really well, how do they manage to get a diagnosis really early?